Hello, everyone, and welcome to our Spring 2022 Town Hall meeting. I'd like to start by thanking each of you for your hard work over the last 2 years and specifically during the most recent surges. Many of you worked extra shifts, continued to improve outcomes, and truly coalesced around one great team to demonstrate our commitment to our friends, family, and members of our community. To you, I say thank you as you've clearly demonstrated the UNC Health vision that we are better together than we are apart, and our effective collaboration is key to providing quality care. I'd like to welcome the newest members of our leadership team, our new chaplain, Dr. Patricia Wright, our new physician recruiter, Dylan Black, our new HR director, Chris Blackman, our new EVS director, Legarius White, and our new director of patient financial services, Sonia Collins. I also want to welcome all of our new teammates, physicians, and APPs that have joined our team since our last town hall. I also want to welcome our clinical helpers, a new role that we've introduced that's already helped us to reduce our falls in the hospital. We would not be able to do it without you, and again, welcome to the team. I'm very happy to introduce today Ms. Jen Bailey, our Director of Risk Management and Corporate Compliance, and our Patient Safety Officer, as she discusses the impact of culture on outcomes and patient safety. Welcome, Jen, and the floor is yours.
This presentation will look at the impact of culture on outcomes and patient safety. We'll look at the importance of a culture of safety in an organization. We'll touch on some areas of risks here at Wayne UNC, why we need to make change, adverse event reporting, and then we'll close looking at Patient Safety Awareness Week and the Patient Safety Culture Survey. So in 1999, the Institute of Medicine report To Err Is Human estimated that 98,000 people died each year, secondary to preventable medical harm. That number increased into 250,000 in a 2017 report. These reports called upon organizations to seek to understand safety events to prevent future deaths and to develop a culture where beliefs, values, and norms support and promote patient safety. And that culture reaches throughout all levels of the organization, keeping safety as a shared priority. When everyone is focused on safety and on patient safety, then a culture of safety will develop. We must recognize that cultural differences exist between departments, shifts, and even team members, and we have to determine what practices we will accept and reject those that do not promote patient safety. One person can negatively or positively affect a unit's culture. Some areas of vulnerability at Wayne will be discussed next. The first area is communication. In 2012, Joint Commission recognized communication problems as the root cause of sentinel events 59% of the time. In 2015, that number had increased to 79%. We can control communication errors through clear and accurate written documentation in the medical record, and a complete verbal handoff as we're transitioning care from one person to the next. The medical record is the main communication tool that is used by all teammates to plan, coordinate, and document what we did with the patient. It tells the story of what happened. We must look at the medical record as a storybook that we can open and we can turn the page to see what happened yesterday or a week ago, and that we can refer back to that to gather information to plan what our next entry into that book will look like. What we document and the quality of what we document has an impact on the safety of our patients. If we omit critical parts, then other caregivers are not going to be able to see that information, and they will not be able to put in orders or act upon abnormal findings if we do not make those entries in the medical record. The quality of documentation often equates to the quality of care, especially when charts are being reviewed for litigation. And the quality of that documentation can often determine the outcome in a litigation. If it isn't documented, it wasn't done. That adage never holds truer than what it does whenever we're reviewing a medical chart in a malpractice trial and trying to piece together parts to make the story when there's pages that are ripped out that would be helpful to have. So I often say that whenever I'm talking about documenting, to dance like no one is watching, but document like we're reading your notes 6 years from now in a deposition. I know that sounds extreme. 6 years is an awful long time, but that is the average life cycle of a medical malpractice trial from the time of injury until the time it actually gets in front of a jury. I know if I didn't have something to go back on and review that was really clear and painted a story, I would not be able to testify appropriately as to what happened 6 years prior. So that's why making sure that what we put in that medical record paints that story completely, so that if we have to go back and read something later, we have that to fall back on. A failure to communicate promptly and appropriately for the situation and a failure to adequately document medical care continue to be the two factors most commonly associated with all medical liability claims. So that's why whenever we have abnormal findings, it is critical that we communicate these findings appropriately and promptly to the caregiver that is most responsible. For instance, if we find abnormal vital signs, then we need to let the nurse know. And then it's the nurse's responsibility to notify the physician so that we are closing the loop and getting the appropriate care for the patient. All of these aspects of documentation fall into common liability claims. So a failure to diagnose, a failure to follow up. How we document this determines the outcome quite frequently in liability. A failure to treat, including delays in providing appropriate treatment. A failure to refer for screening. For instance, if a patient has an abnormal finding on an x-ray, we must make sure that these findings are called to the appropriate physician, and the physician has to refer that patient for follow-up care. A failure to monitor, including delays in the application of remote telemetry monitoring or extended periods of the patient being off of the monitor. That falls true for both telemetry monitoring and in obstetrics. Not having that mom and that baby on the monitor continuously when continuous monitoring is ordered can be looked at as a failure to monitor. Additionally, documenting medication errors and then informed consent that is unclear or that does not exist are other areas of liability claims that our documentation can either support or erode what we did. So as we're talking about documenting and what makes quality documentation versus acceptable documentation, we need to remember that our documenting should communicate concerns, be accurate, complete, timely, and informative. So we must document for clarity, including specific statements that the patient made in quotations, being specific, avoiding general terms and vague expressions, using standard abbreviations appropriately and not making up our own, documenting safety precautions that we're taking, for example, documenting that we assisted the patient to the exam table as opposed to the patient got on the exam table. There's areas of risk there. And then making sure that we are documenting objectively. A subjective note would read, the patient is not taking medication. That leaves a lot of questions still unanswered. Objectively documenting the same thing would state that the patient stopped taking Cozar HCT a week ago because she became very dizzy and felt like she would pass out after each dose. That paints a full story of why she's not taking her medication. When we're looking at pre-printed forms and checklists, this is an area of omission that whenever we're leaving things blank and we're omitting things on that document, that opens us up for scrutiny. For example, if we leave a blank open on a checklist, does it mean that it's not applicable? Did we not ask the patient? Does it mean no? Or was the patient unable to answer? There's a lot of questions left unanswered. So whenever you're completing these pre-printed forms and checklists, make sure that you complete them fully, that all the blocks are filled in either with an answer or with NA or a blank, a line through the box. It's very important that as we are completing this medical record that we obtain a current problem list that includes chronic and recurrent medical problems and illnesses for the patient, that we're assessing tobacco, alcohol, and substance abuse. We're looking at drug, food, and other allergies and adverse reactions, and that they're documented in the medical record so that people can go in and see them. Medication reconciliation is very important. And this is an area where we can either miss medications in the hospital, we can double up on things accidentally. So it's very important that we involve the patient to find out not just what they were prescribed, but what exactly are they taking, including any over-the-counter medications and herbal supplements. So once we have a clear picture of what they're actually taking, that will help drive the care in the hospital better. We may be treating a patient that comes in for chronic hypertension only to find out through medication reconciliation that they haven't taken their antihypertensive meds for the past month because they couldn't afford it or they ran out of refills. So if we were to add on a second medication, that could have disastrous consequences to someone if they were maintained on one medication prior. Remember that our elderly population and our pediatrics are the highest risk for medication errors. People over the age of 60 account for half of fatal med errors, and children are especially vulnerable because of their doses are based on weight, so the calculations are critical. That is why it is so important that we get actual weights of all of our patients, children and adults alike, instead of estimating to prevent over or underdosing of medications, which sometimes can be fatal. We also need to document special entries and screenings per policy, including your fall assessment, precautions taken, patient education that's provided surrounding fall prevention, pain assessments and reassessments after interventions are provided, vital signs, intake and output, medications, other treatments, all must be recorded at the time of completion so that record stays up to date. Any abnormal findings need to be reported to the nurse to send to the provider, and critical lab values must be called to the provider within 1 hour per policy. Any patient changes must be immediately conveyed to the provider so that they can assess and intervene on the changes that you at the bedside are seeing. Do not delay your documentation. Remember, your documentation transfers that story into the book for others to read. And it's critical that your documenting is timely. It must be completed before the end of the shift at the absolute latest, remembering that omissions and delays will compromise care. Patient education and discharge teaching is a very critical component of the medical record to close that record out. We need to document formal and informal training describing the response of the learner. Were they able to provide a verbal articulation back to us of what we taught them, or can they do a return demonstration? Make sure that our teaching plan is up to date so that the next person can continue and reinforce necessary training. And at discharge, it's important that we obtain one last set of vital signs and a pain assessment and document that in the record, that we review the instructions and provide the patient an opportunity to ask questions, and that we note a level of understanding, including the patient knowing when to follow up for additional care or when to come back or seek medical attention if their condition changes or worsens. So what does your documentation say about you? Remember, we said that the quality of documentation is often equated to the quality of care rendered. So we want to make sure that our documentation shows that we provided that safe environment for the patient, protected them from harm, that we monitored for foreseeable complications, immediately identified concerns to a responsible person. We followed up appropriately on lab tests and procedures and followed policies. We gave medications correctly, including barcode scanning every time. And we provided the patient with information to facilitate safe care and patient engagement at home. The next area of vulnerability is handoff communication. Remember that communication gaps are estimated to contribute to 79% of medical errors. We've talked about the written component of communication, and now we'll talk about the verbal component. Your handoff should be thought of as your pre-flight checklist. It's something that we do the same way every time so that we don't miss important steps. The process must be standardized. And whenever we provide handoff, it needs to be at a sacred space and time. So that moment needs to be protected from extraneous commentary and limited interruptions so that the focus is on the patient. Using a structured tool will allow us to remain on task, and then we can monitor the use of that tool and impact on patient safety through audits and through the SAFE system. So handoff is the most dangerous time in a patient's hospital stay. And these handoffs include shift to shift, department to department, facility to facility, but it also includes us handing off our patients to our EMS and transport providers. They play a critical role in the patient's care as well. Whenever we are transferring a patient, we must document that we gave report first and foremost, and then document a full name, first name and last, and the title of who received report. Document all conversations with providers, even if you don't receive orders, because this shows that you recognized an issue and you communicated that issue to someone who could make an impact on the patient. The IPASS tool is looked at as the industry standard for handoff communication. A study done by the IPASS Institute whenever this tool was being developed showed that handoff effectiveness is overestimated. And 60% of the time, the most important piece of information was not communicated. That's why IPASS was created as a standardized approach to conducting handoffs to reduce the likelihood of communication failures. So this tool is your pre-flight checklist that we spoke of, and it provides you with both a verbal handoff and a printed document to safely hand off the care of the patient. SBAR, which is something that this is a tool that most of us use currently for handoff, is really not a handoff tool. So SBAR is a technique for communicating critical information that requires attention and actions concerning the patient's status. So it is not something that is comprehensive in handing off all aspects of the patient from one place or one person to the next. The iPass tool, however, goes over a comprehensive standardized list of areas to review with the person receiving report. For instance, is this patient stable, unstable, or are they a watcher? And a watcher is defined as, someone that can go either way, or someone that really evokes that gut feeling that something's just not quite right. I think we've all experienced that in our career, where we just have a gut feeling that something is not quite right with the patient, but we can't put our finger on it. Those are the ones that we would put in that watcher category. Then you have the patient summary, and this is the events of what led up to the admission, what's been going on with the patient while they've been here, what is the plan moving forward. An action list including a timeline and ownership. For instance, the patient is going down on Tuesday to have an MRI completed. Situational awareness and contingency planning, knowing what's going on and planning for what might happen. If the patient has been unstable and is progressively worsening, awareness that a code may need to be called or an RRT may be called on that patient during that shift. It's important to know for that so that you can plan for that potential. And then finally, the most important part is that synthesis by receiver, where the receiver can summarize what they heard about the patient. They have time to ask questions, and they restate those key action items and to-do items so that both parties understand what needs to be done to get the patient home. So when using iPass, from the day that the person is admitted, you're focusing on achieving all of these tasks on this to-do list to get the patient home. So you're always looking forward to discharge day using this tool. This is a really good example of what that synthesis by receiver really looks like. So whenever you're placing your order at McDonald's, for instance, they have these visual boards that show everything that you ordered right there on the screen. So you're telling the person on the headset what you want to order, and they are showing your order up on the screen as you tell them, so that you can verify the accuracy of it. So with the synthesis of the receiver, it's that closed loop communication that you're looking for. The message is sent, the receiver accepts the message and provides feedback, and then the sender again verifies that message was received to close that loop. So again, talking about handing off patients outside the facility is really a critical point whenever we hand this patient off, because we can't pick up the phone or run down the hall and ask a question about the patient once they're out the door, driving down the highway or at another facility. So once a patient is accepted to an outside facility, call report to the receiving RN, again documenting their full name, first name, last name, and their title. Follow that iPass standard handoff tool when calling report to another facility. Once transport arrives, it's important that we complete a face-to-face bedside handoff with the crew, again using iPass. Remember that transport does not get a report from anyone but you. So if we don't give them a report, they have absolutely no idea what they need to do to take care of that patient while they have them in their care. Your EMS and transport providers would include Wayne County EMS or other municipal system that may take a patient out of the organization for one reason or another. Hospital-based air and ground services such as East Care, UNC, Rex Hospitals, ambulance, private transport services like MedX or North State. These providers must have the knowledge, again, to effectively care for the patient until they are received at the receiving facility. We need to make sure they have demographic sheets, images on a disc, and any medical records that are necessary for continued care, copied and ready for them when they arrive. EMTALA forms, physician certification forms, and billing forms must be completed in their entirety and handed off whenever they arrive to pick up the patient. Also, nonverbal communication is very important to keep our patients safe, and that would include things like our armbands. Making sure that we have the right armband on the patient, physically affixed to the patient, not the door, not the floor, not the bed, not the chart, but actually on the patient. And that armband can be scanned and is readable. Any type of alert bands, fall risk bands, DNR bands, things like that, it's important that those are placed on the patient because, again, they convey a message, a nonverbal message to someone that is looking at those bands. Remember that we use 2 patient identifiers every time to identify our patient, even with an armband on, and that is the name and full date of birth, month, date, and year, not just the month and the date. Also, one final thing when we're talking about transferring patients and handing off patients from one place to the next, don't forget their belongings. So part of that handoff from one unit to another or one facility to another must include their belongings. So when we lose their items, it is a monetary and reputational loss for the organization. Some things we can replace and some things are irreplaceable. For instance, the wedding ring that was worn by a patient for over 6 decades that was lost, or immigration paperwork that they've had in their wallet for decades upon decades, or photos of deceased family members that are irreplaceable. These types of things carry a value much higher than any monetary value that we could put on them, and we must protect these things that belong to our patients just as if they were our own. Remember to follow policy when it comes to valuables, sending things home when possible, or securing valuable items with the police department, inventory items on admission and with each department transfer, and document that in Epic. If valuables remain at the bedside, have the patient sign that release of responsibility. This does not release us from doing our part, but it does place some responsibility back on the patient. We still have to make sure that we are moving the items from one room to the next. Remember that cell phones, computers, and tablets are no longer covered if lost or damaged. And upon discharge, it's critical that we document what was given back to the patient. And if it's not the patient that gets those items, who received the items and what they received. So to change and to push this culture of safety and embrace this culture of safety, we must first change our mindset. So we cannot focus errors and look at errors as merely a sign of incompetence and something went wrong. We must recognize that anytime a human is involved in a process, an error will occur. So we have to anticipate and expect that something bad is going to happen and focus on promoting safety and preventing those things from happening. We have to be proactive and look to be different to gain better outcomes. So we will look and evaluate errors and mishaps using the Just Culture algorithm and look at the error as an opportunity to learn, improve, and prevent recurrence, recognizing that everyone plays a role in preventing harm. And finally, we have to defer to expertise, recognizing that someone at the deck plate or a new teammate may have more knowledge or more experience in a situation than we do. And we have to break down those hierarchical challenges and find the person that is the most knowledgeable about a situation to help us move forward. I spoke of the Just Culture algorithm, and a fair and just culture is not a punitive or blame-free environment. It is an environment where the system and teammate accountability is balanced, and we are consistent with rewards and punishments. And only through maintaining this consistency where both the system and the teammates do their part can we begin to change culture. So teammates have a responsibility to do their job to the best of their abilities, and leaders have a responsibility to make the system safe and system design work for us, but also to hold teammates accountable for actions that are not within standards. So as we move from acceptable to exceptional, we have to realize that when patient safety fails, our reputation in the community fails. We must recognize and prevent and mitigate harm, because that has the greatest potential for positive effect. And finally, we have to remember the purpose of why we're here. Every single patient lying in that bed is critical to our mission. They are the reason why we're here, and we have to put them first and foremost at all times. You all play a role in keeping patients safe, so speak up and be safe. If you see a safety concern, cuss, I'm concerned, I am uncomfortable, this is a safety issue. Advocate for the patient, follow your chain of command, and enter a safe report. Reporting of events, we should be reporting any deviation from the standard provision of care or routine operation of the hospital, including inappropriate and abusive behavior of patients, visitors, teammates, and providers, even if an injury did not occur. So if, for instance, if a patient throws something at a teammate, but it doesn't hit the teammate, that is still abusive behavior, and we need to know about it so that we can put protections in place. Wayne UNC policy requires that the teammate involved in the incident is responsible for immediately entering in the event into the safe report. Make sure that whenever you enter that event that you're not using names of individuals in the narrative, that you're entering those in the bottom section, parties involved, notified, and bystanders, and that you're being objective and brief. Do not copy from the medical record. We want to make sure that you're summarizing the event, but not copying and pasting from the record. People often do not want to report mishaps. They fear reporting a mishap because they're afraid that they're going to get in trouble, or people are not going to want to hang out with them because they're tattling. They're afraid they may lose their job, or they have feelings of shame when they may have contributed to the error occurring. But remember, it is through these reports that we learn and we improve, and that we are focusing on preventing harm. So it's very important that we know about things that happened to the patient or could have happened, those near misses that didn't actually hit the patient. Those are the ones where we really can learn the most, because an injury has not occurred. So all of these things we need to know about. You can enter an event anonymously, or you can enter your name into the system. Either way is fine. If you want to remain anonymous, then certainly do so. If you fear even entering that report into the system because you feel like some way it may be tracked back to your U number, please give me a call or call the patient safety hotline. The hotline is 587-4444, or you can call me directly at 731-6313, and I will be happy to take that report and enter it on your behalf. So when a mishap occurs, it's also critical that we document the incident in Epic, and that we are describing it objectively, avoiding words such as accidentally, mistakenly, inadvertently. Make sure you document an assessment, including vitals, the name of the provider that you notified, any orders received, any interventions you did, and then make sure you're being factual and do not speculate about what caused the incident or how the patient is after the incident. Advocate for your patient, follow the chain of command. If you do not get what your patient needs, use that chain of command, and then reach out to risk management anytime that you have a concern. Other ways you can protect the patient is help them communicate and connect with family at home. Keep that whiteboard up to date so that they know who you are, what date it is, what their goals are, and then ask them questions. Engage them in what you're doing. Ask them what they enjoy doing outside of the hospital. What was their occupation? Do they have children, grandchildren, pets? And then get on that personal level, but keep it about the patient. Make sure that the focus stays on them. Okay, now we're going to take our smartphones out for the conclusion of this presentation and open up your camera app on your smartphone. So point your camera here at this QR code and follow that link, and that will take you to the Patient Safety Culture Survey. The survey opened on March the 1st and closes on the 31st. Takes less than 10 minutes to complete, but your input can help save a life. Every single voice is important and we need to hear it. And remember, this is absolutely, completely anonymous. There's one QR code for the entire organization. There's no way we can track it back to you. Departments of less than 5 individuals roll up into an aggregate, so even your responses are totally anonymous. This is the link that you can go to, https://www.patientsafetygroup.org/s/WUNC2022H. That will also take you to the survey. So we said that it is anonymous, and this is what we see. No names, no ID numbers, and no way to track you. It will show a total number of responses per date, and then a total number of responses and total number of employees per department, but that's it. And then if it's an area that has less than 5 teammates or less than 5 responses, you'll get the notification that to keep the survey anonymous, we don't show scores if there's less than 5 responses. Your input is valuable. You are valuable to this initiative. Again, survey results are ranked on a 1 to 5 scale. And from the survey, the leaders will develop action plans based on your scoring to help drive us forward in developing that robust culture of safety. We can't correct what we do not know. Finally, Patient Safety Week is March 13th through the 19th. So as the slideshow is launching, we will be in the midst of Patient Safety Awareness Week. So be on the lookout for some daily newsletters with tip sheets, educational webinars. Some even have CE credits. There'll be a word search, and in room 638, there's a room of risks for you all to go through and see how good of I Spy you are in finding risks and things that are not done per policy in a patient's room. There'll be a patient safety commitment banner that will hang at the employee entrance for everyone to sign. And then finally, a reminder that the survey ends on March 31st. And again, there's that QR code if you missed it on the slide before. So please take 5 minutes, 7 minutes, and complete the survey and engage in some of these activities that are planned for you. There are 2 opportunities with the word search and the room of risks to win some prizes with that. So make sure you put your name on your forms and leave them so that we can put you in the running for some prizes. So that's all that I have. I'm going to toss it back to Dr. Tucker so that he can make some closing remarks. And thank you so much for this opportunity.
Thanks, Jen. That was a great presentation and great information that we can all take to heart and, more importantly, take to practice. As we move further away from this most recent surge, I ask that we all refocus our efforts on quality and patient safety. Our hospital leapfrog grade is a grade of A, and that's the highest grade possible. And I want us to work to sustain that grade and improve our CMS star rating, which is a 2 out of on a 5-point scale. So we have some opportunity there. Let's ensure that every shift change has a detailed and collaborative handoff. iPass, I think, is the tool that Jen mentioned. Let's work as a team to ensure that every patient is escorted to the restroom every hour to reduce falls and other patient harm, and move to increase our collaboration and discussion across disciplines. The care team around our patient, who in our small community is likely to be a teammate's loved one, should be the focus of our work. I want to thank you for your time today, and I look forward to seeing you as I round the hospital. Thank you.